Okay, so this patient was actually initially presented to Hospital Sungai Buloh back in September 2023. So she is a 52-year-old lady with underlying diabetes for about 13 years on metformin, but no proper follow-up. She just buys over the counter. So she presented to Sungai Buloh in September with a 3-month history of on-off spiking fever and constitutional symptoms, including significant weight loss of about 15 kilograms, as well as reduced effort tolerance. So at that time, she was noted to have pancytopenia, HP of 6.4, white cell of 2, and a platelet of 120. At that time, she was treated for an underlying infection and subsequently a full blood picture. I don't have the original full blood picture that was done in Sungai Buloh, but it was just reported as hypochromic microcytic cells with some neutropenia, lymphopenia, and a true thrombocytopenia. And subsequently, throughout the course of the admission, somehow they decided to proceed with a bone marrow during the initial admission on the 20th of September. But subsequently, the fever settled and the patient was discharged and given an appointment to review her marrow slides about a month later. Unfortunately, she presented prior to her appointment date again with similar symptoms. She was hypotensive this time, and she was transfused about 3 pints of blood and also given antibiotics. So at this time, so actually they sent a lot of investigations. These investigations were sent during the first as well as the second admission. So a whole load of tests for CMV serology, EBV serology, malaria, even autoimmune screen, ANA, rheumatoid factor was sent, which were all negative. Viral screening was negative as well. Cultures were all negative as well. And when they reviewed back her bone marrow report, at that time, it was noted to have increased in macrophages with hemophagocytic activity seen. So at that time, they're thinking about HLH. So they sent the ferritin, and the ferritin was raised about 7,500. However, the fibrinogen, the TG, and all were within normal range. So she was subsequently referred to Ampang, and we took over the patient at the end of October. So in Ampang, when she presented to us, HP was 9.9, a WBC of 2.2, and platelet of 121. There was hyperferritinemia of 14,000, and also hypertriglyceridemia, but normal fibrinogen. So we sent off a full blood picture, and we also repeated a bone marrow on the 1st of November. So in our center, we sent off her EBV PCR as well, because at that time we were thinking, we were investigating what could be the cause of the underlying HLH, and her EBV PCR was detected. So, the next FPP and bone marrow slide.
It's interesting to find that actually the EBV is positive in your site, whereas Sungai Buloh Infection Hospital is negative. Huh?
No, I think they did serology. Ours
it's a serology. Your is a PCR, more sensitive.
Correct. So we looked at different entity.
Okay.
Yeah. No.
Okay, so let's have a look at the full blood picture. So at this juncture, the counts is the HB is 9.1 with a normochromic normocytic red cell indices. Platelet is platelet is normal, 187, and the white cell count is 3.23 with a neutrophil count of 1.92. So he has a bicytopenia, or she rather. Sorry.
Yeah. What about the lymphocyte count? Is it lymphopenia?
The lymphocyte count is indeed lymphopenia, Prof.
Oh, okay, right. Without having lymphopenia is a serious problem.
It's already giving you a clue, is it, Prof? So the bone marrow was the peripheral blood film was reported with to have a leukoerythroblastic picture, but as usual, when I want to find a leukoerythroblastic picture in this short space of time, it's always challenging. No, that's not 1%.
So the routine machine also suggests there is nucleated red cells lah.
NRBC count was NRBC. Oh no, sorry. The machine said there's no NRBC.
I see. Okay. So they haven't identified any. But anyway, it's a serious problem about pancytopenia. But your platelet count will say is normal.
Yeah, 187.
It doesn't look like the blood film. Is it? The blood film doesn't look like normal. Was it normal?
No,
Slightly low
Yeah.
on the blood film, but there was a little bit of clumping. But it is on the lower end lah. It's on the lower end.
No, it's just to look for justification for the donor bone marrow. Normally, a person who has got pancytopenia, most of the physician will do it's an indication for a bone marrow lah.
Yeah.
Unless there's an obvious cause.
I think the indication here was that the fact that there was a leukoerythroblastic picture, which I can't seem to find right at the moment.
It's okay. It's when you want to find it, it's difficult to locate.
Yeah.
yeah, it was also part of the diagnosis. I mean, part of the workup for basically prolonged fever, because she did have prolonged fever.
Yes, that's right. 3-month history on and off of fever. Definitely, it's a serious problem to investigate.
So this is a 52-year-old female. Again, slightly hypercellular for age, or maybe, but maybe it's only slightly, not as hypercellular as our patient just now.
Yeah, 52 years old. Yeah, okay lah.
Yeah.
Borderline hypercellular lah.
Yeah.
Yeah, it's quite cellular actually. The cell trail.
Yeah. But what is most apparent if you go through the slides is the fact that she has very marked hemophagocytosis.
Oh yeah, so obvious.
So as you can see, the 2 neutrophils in the belly of one macrophage, and then obviously the histiocytes are increased.
Not everybody is hungry, only some.
Yeah, only some, yes, not everything. Not all.
But there's a lot of histiocytes.
Yes,
So
definitely.
Just
It's very
in, this,
obvious.
just in this field, you can see what, 4, 5, 6, 7 histiocytes.
Yeah, many.
So the hemophagocytosis is very apparent. Again, here in the middle of the field, there's a histiocyte eating, I think. That's the that one, yeah. But otherwise, if we were to comb the marrow, again, it's hard to identify the abnormal cells, or hard to say that there is presence of abnormal cells. The background seems to be very reactive, with a lot of granulocytes and the normal hemopoietic elements and lymphocytes. But what we do see is the presence of this hemophagocytosis. Whether or not truly there are abnormal lymphoid cells was very difficult to tell.
It's difficult from a bone marrow aspirate. The only
Yeah,
thing you can make a diagnosis is the hemophagocytic syndrome. That's all. Yeah.
correct, correct. Here it's busy eating platelets. Mopping up the platelets. Very increased histiocytes, a lot of histiocytes, huh?
Yeah.
Fine, yeah. Here again, side by side, two very hungry macrophages.
Yeah. Wonder you have got iron stain. Maybe quite interesting to look at the iron stain.
We do have it, but I don't have it handy on me.
Oh, it's okay. Don't worry.
We did iron stain, but I don't have it handy on me. So compared to the first case, this case seems to have a little bit more lymphocytes, whereas just now a lot more was more granulocytic hyperplasia, eosinophilic. But this one, looking in the background, slightly more lymphocytes. The granulocytic hyperplasia is not seen. Reactive, but in a more sort of a chronic reaction rather than an acute reaction.
So just now the one is granulocytic hyperplasia. This one is more slightly we have got a lymphocytic population. Yeah, agree.
Betul.
That explain why I got 3 months off and on fever lah.
Yeah, yeah. So a more drawn out process.
Yeah.
Rather than like your ALK positive ALCL, which is more acute in presentation. But itulah Prof, we can't really appreciate the abnormal cells, kan?
Not obvious.
Not obvious. Not as obvious as the case just now, where we could at least identify in every field 1 or 2 sort of abnormal looking cells.
Yeah.
Here it's a lot harder. So it's become a bit of a practice in hospital here at our lab, that if we have a HLH, one of the first things that we exclude is EBV infection lah.
Yeah.
So
but cannot stop. Even you identify EBV also, you cannot stop. You have to look for underlying other things.
Correct. But if we were to rely just based on the aspirate and that, you wouldn't think of anything else but maybe a HLH secondary to an EBV infection.
Yeah.
But when we look at the trephine, it tells a bit of a different picture. Okay. I'll just go low power sekejap. So not as hypercellular as our patient earlier.
More fat.
More fat spaces. I think we can all appreciate that. I apologize that the trephine is a bit fragmented and hemorrhagic, but we can still appreciate the cellularity lah. And what I want to draw your attention to is that although cellularity wise it's normal, but if we look at the topography, it's abnormal. So again, you have a dysplastic sort of topography where your erythroids extend to your paratrabeculae, and then you see a lot more sort of young forms or young cells in the interstitial area. So something's going on.
And then the mega go to the paratrabecular area.
Yeah, correct. So again, this can also be another red herring. This could be like a MDS sort of feature.
Yeah.
But as we know that features of dysplasia can also be caused by secondary causes. So it's not necessarily a primary MDS. And then
correct.
the other feature that I also want to draw your attention to is in some areas, it looks as if there's a sort of like a desmoplastic reaction. Very fibrotic looking, looks like a lot more fibroblasts, a lot more fibrous cells rather than hemopoietic elements. So as you can see in this bottom half. So again here, almost looks like a granuloma.
Yeah, it's a granuloma, I was about to say.
Yeah.
yes. Looks like a granuloma, all right.
Activated macrophage, slipper-shaped looking cells. So it's something's going on lah. You don't know what's going on, but something is not right.
Well, then you have to look for differential diagnosis of granuloma in the bone marrow.
Again here, you can appreciate in the middle here. And also here. But if we go higher power, there is presence of some large cells. With prominent nucleolus. That one cut in the middle there.
What are those cells there?
Yeah, exactly. I mean, at this point, it could be anything. It could be those, the many number of histiocytes.
It's like granuloma got giant cells, you know.
Itulah. Okay, so we did our sort of like a slew of IHC. And of course, we do your usual CD20, CD3, and because we saw large cells, we did a CD30. What would you like to see? What would you like to see first, Prof?
Well, you show the negative one first, lah. Relevant negative.
Bear with me. Okay, so I'll show you CD20 first.
Go and see 730. See how the immune response like in this bone marrow. CD20, what they call CD3.
Okay.
See how the body respond to it.
Yeah. So this is CD20. As you can see, CD20 cells are much reduced.
Oh, nothing very much, huh?
Nothing very much at all. So although there's a vague nodule here.
Oh, there's a follicle there, lah.
Yeah, and this is the area that I highlighted just now, Prof. That granuloma looking area. As you can see, in between those cells, those CD20 cells, you'll see those slipper-shaped, elongated nucleus. I think you should be able to appreciate that. So this is that area where I said had a lot more activated macrophages.
Yeah. Okay. But this one you are labeling actually the B cells, right?
Yeah.
Correct.
Yeah. Okay.
And again here, there's one sort of large vague nodule here.
So the nodule have got these aggregates, not really exactly aggregates, like infiltrates of B cells.
Yeah, very few. So I'll show you CD3 as
It would be interesting to see the T cell as the CD3. Yeah.
So this is CD3. So as you can see, CD3 is a lot more, so much more.
Okay, all right, yes.
So the lymphocytic cells that I see in the aspirate is mainly contributed by your T cells.
It is an immune response, lah. Yeah, because the T cells are the one is reactive, and then of course the T4 cells will call in the B cells. Yeah.
So here was that nodule that I showed you earlier. And the other one
yeah, that's right.
Here,
Yes.
the larger nodule, the larger vague nodule that I showed you earlier.
Okay.
So it's reactive, but it's mainly T cells.
Mm.
Okay.
They
So
got,
now
yeah.
I will show you
Do
CD
you have macrophage stain?
microphage stain. Ada, Prof?
See how is it like? Let's see how whether you outline the what we call the granuloma or not.
Yeah. Unfortunately, the apa tu? Macrophages are a lot.
Oh,
There are a
Aiyo.
lot.
oh yeah,
Yeah,
yeah, because
increased.
yeah, that's right.
Yeah.
Because histiocytic proliferation now.
So the nodule that I pointed out just now was this one.
Yeah,
Here.
even more intense. Very
And
intense.
this was the other vague nodule, but it's widely increased in all the areas lah.
Yeah. But all the nodules that just now you see actually are more intense, right?
Yeah.
So
Yeah.
so it fits into our original observation that you actually got granulomatous reaction in the bone marrow.
Betul.
I think we don't know what is it against.
Okay, so when we because we saw those large cells, we also do a CD30.
Okay.
Okay. And this is CD30. Can you see, Prof?
Yeah.
So the CD30 is picking up large cells.
Yeah. No reason to be there.
And one of them is binucleated.
Oh yes.
So with
Ah.
the fact that there's a CD30 positive cells, you have HLH, and you have this sort of inflammatory response in the background. We started to think of Hodgkin's lah, Prof.
Yeah. You're not
Especially
thinking of ALCL also,
again, right? Yeah, exactly. But doesn't Hodgkin lymphoma typically have lymphopenia, Prof?
They do. Yes. Indeed, you're quite right. Yeah. Hodgkin's, you tend to have lymphopenia rather than lymphocytosis, whereas non-Hodgkin like ALCL will be tendency to have lymphocytosis.
Yeah. So we also then had to do more markers to exclude Hodgkin lah. So now we'll do a CD15. So
This one not so complicated. You don't have granulocytic hyperplasia.
yeah, exactly. So it's not as difficult, and because there was that nodule which was predominantly consisting of histiocytes, lymphocytes, and those large cells, and not much granulocytes, so you have an area where it's clear from your positive granulocytes, and as you can see, there are some positive cells. And what I want you to see also is that typically in Hodgkin's, your CD15 stain can be quite weak, and it's only intense in the Golgi area. So if you can see that there's a dot just outside of the nucleus, that is that Golgi area. So CD15 typically stains that Golgi area of your neoplastic cells.
Very clear, very beautifully illustrated. Staining of the Golgi apparatus. Yep.
So this was so much easier than the previous case because you have that area, area to sort of demarcate the neoplastic cells.
Yeah.
Whereas in the ALK positive case, your neoplastic cells was embedded within all your granulocytes, so it was difficult to use CD15 as a good marker.
Yep, certainly.
So I hope I've convinced you that it's CD30 positive and CD15 positive. Now, as we know, the Hodgkin lymphoma cells are typically CD20 positive, which is why they didn't pick up the CD20. but they are of B cell origin, and they are often positive for PAX5. So here is a PAX5 stain, and a PAX5 is a nuclear marker. So again, zooming in that nodule that we saw earlier, the PAX5 will of course pick up your normal B cells, but it will also pick up the abnormal cells or your neoplastic Hodgkin cells. They will stain slightly dimmer than your normal B cells. So case in point is this binucleated or your Reed-Sternberg cells, which is slightly dimmer than the smaller positive PAX5 B cells. And again, this one here, your PAX5 is a lot dimmer. So it's in keeping again with the Hodgkin lymphoma diagnosis, where your bigger cells or your neoplastic cells are weaker in stain. Again here in a different area, but similar. So the smaller cells are positive or darkly staining, brightly staining, and then your bigger cells are not so bright.
Do you have a retic stain?
Retic stain.
Kita
tak buat, Prof.
Oh, okay, never mind. Because earlier on you look like the fibroblastic nature of the granuloma. Was wondering how they look like. Of course, when you have a granuloma, normally you also do some fungal and mycobacterial staining.
Yeah.
Some secondary infection.
Okay, so just last one, I will show you also an EBER stain. Because patient was EBV positive, we wanted to know whether it was also a driver for this lymphoma. So in about 35% of cases, you will have EBV positive neoplastic cells.
So you have to go and zoom into all the CD30 positive cells.
Yeah. So there are some positive neoplastic cells, as you can see.
Yeah,
So,
yeah.
Not all, but some. So suggesting that there is EBV positivity lah. So even when we go to the other areas where it's not so clear, all the EBV positive cells or the EBER positive cells are the large ones, the large neoplastic Hodgkin cells or Reed-Sternberg cells. So I hope I've convinced you that this is a case of a classic Hodgkin's lymphoma. I have the iron stain now, Prof. Would you like to see?
Oh, okay. Let's have a look. Oh, wow. Loaded the ferritin. Remember the ferritin was very high.
Yeah, the iron stain is picking up all the ferritin, the iron stores. So definitely increase lah.
Okay.
Okay, so I hope I've convinced you that this was a case of classic Hodgkin's lymphoma with HLH, probably secondary to the Hodgkin's lah. So I'll pass it back to Dr. Vishnu.
Yeah, I think the granuloma is associated with underlying Hodgkin's in the bone marrow also. Yeah, not reported to be associated with ALCL. So therefore, I think it does support that your observation. This is a case of Hodgkin's disease. Now the only thing is to question this the EBV virus. is it the HLH related to the Hodgkin's, or is it actually the underlying driving mechanism is actually the EBV infection that drive both condition?
That's a tough one.
Yeah.
It's very difficult, Prof, to determine that, because the thing is, yes, it can be associated to EBV infections, can be associated, but the thing is, which is the chicken or the egg? It could be maybe what do you call this, a chronic EBV infection that has now predisposed to Hodgkin's lymphoma. That's a possibility. Or it could be two concurrent things that it has happened together lah. But in all honesty, for her case, we didn't treat the EBV per se. We just treated the Hodgkin's, and she's actually recovering well.
Yeah,
So,
because the Hodgkin will be probably more aggressive disease, is it? In
Yeah,
this
right.
case, rather the persistent EBV infection.
Yeah.
Okay. All right. Okay. So usually when you're HLH, you're more likely to encounter a non-Hodgkin rather than Hodgkin's, you know.
no, actually no. We have seen many Hodgkin's. This is actually probably the 5th or 6th Hodgkin's.
Really,
Uh,
So that means your series is quite different from what is being reported, you know. If you look at the people reporting HLH with hematological malignancy, the bulk of the cases are actually non-Hodgkin lymphoma, rarely in leukemia or Hodgkin disease. But
Okay.
your experience may be different.
Yeah, maybe. I don't know. I mean, yeah. I don't know, when we were told when faced with a patient with HLH, always look out for a Hodgkin's lymphoma. I don't know. I don't know. Maybe.
But if you look at the literature, I don't know. I suppose it's Western literature is quite different.
Yeah.
But
But maybe when referring to the non-Hodgkin's, is not the B non-Hodgkin's, but perhaps the T cell non-Hodgkin's and the more immunogenic NK cell type, I suppose.
yeah. The most common is actually the T and NK type
Yeah.
of non-Hodgkin's that actually associated with
HLH.
HLH. Yeah, that's right. Yeah.
But I guess because we see more
Hodgkin's,
rather than
yeah.
T cells, so
It's
Yeah.
very strange because Hodgkin disease among Asian is not supposed to be common, you see. So on the other hand, you actually see more.
Yeah.
Okay, that's the paradoxical observation. Sometimes it often happen that way.
Right.
Okay, good. Thank you very much for this.
Good.
Yeah. Anything else?
Dr. Vishnu will continue with the clinical management of this.
Okay. Let's find out what happened.
So basically, on clinical examination, there was actually no lymphadenopathy or even hepatosplenomegaly. So when we proceeded with the CT scan, actually there were only sub-centimeter abdominal lymph nodes, and basically there was no enlarged liver, no spleen. So it looks like purely the Hodgkin cells were in the marrow and no other nodal involvement noted.
What is the left breast lesion?
The left breast lesion, we actually did an ultrasound. It actually turned out to be a left breast cyst, not malignant.
Okay.
Yeah.
Fibroadenosis most likely. Okay.
So she was first initially started on the HLH protocol with DEXA and etoposide, and subsequently we actually she did have some headache throughout the admission. So we did a CT brain and we also did a lumbar puncture for her. But basically the CSF cytopenia flow, even the EBV PCR, all the results are negative. And subsequently we started her on actually BFCOP chemotherapy, especially because it contains the etoposide as well. So we wanted that in order to treat the lymphoma as well as the HLH that was ongoing. So basically she has undergone about 3 cycles of BFCOP, and this is her trend of her investigation. So her hemoglobin is still quite low, but her WBC has actually improved and her platelet has normalized as well, and ferritin has come down markedly from 14,000 to the latest one is about 2,800. And her EBV PCR repeated this month in January was also actually not detected anymore. So basically just a short, a bit of literature review on Hodgkin and HLH. So as we know that HLH is a relatively rare and multifaceted syndrome and presents with a very sepsis-like picture. And as illustrated by our patient, they can have recurrent fevers and cytopenia, organ dysfunction, and untreated, it has a high mortality rate and can progress to terminal organ failure. So early recognition and treatment is important. And we can have primary or secondary HLH. So in our case, it's a secondary HLH, most likely due to the underlying lymphoma. So as we can see that malignancies are generally more common, as a more common cause of HLH in older age group compared to infections. Usually infections tend to be more common, commoner cause among adolescents and also the younger age group. And lymphomas especially may account for up to 40 to 70% of HLH. Yes, as what Prof. Chong mentioned earlier, most literature review from the West actually note that the T and NK cell lymphomas tend to be more commonly associated with HLH, followed by the B cell lymphoma. Hodgkin lymphoma, not so common. Actually, if you look at the case series, it may range between 6 to 10%. In all the other series as well. So here is a study that was published in 2014. It's a retrospective analysis of 162 patients with HLH. And more than half of them actually had an underlying hematological malignancy. And surprisingly, in this series, B cell lymphomas were more common than T cell, but as you can see, Hodgkin lymphoma, about 10% of the HLH cases had underlying Hodgkin. And then when they followed up the patient, when they followed up the patient, so they found that those patients who had HLH secondary to a hematological malignancy tend to have a sort of a poorer outcome, especially in the first 30 days of hospitalization as compared to infection-related HLH. And this is another study from the US, from Memorial Sloan Kettering Cancer Center, 44 adults over a span of 8 years. Again, majority are T and NK cell lymphoma, Hodgkin about 5%, and the 30-day mortality was up to 36%. And of course, they found that treatment with etoposide alone or as part of lymphoma-directed therapy was associated with an improved survival. And interestingly, they found that they did further mutation studies for these patients, and 5 patients were found to have this TP53 mutation, and all 5 of them actually had primary refractory HLH as well. So they said that maybe this mutation could be was associated with this refractoriness. And this was a study from China. So 28 patients with Hodgkin lymphoma. 8 had HLH, 20 had no HLH, but all 8 patients with HLH tested positive for EBV PCR as well as EBV-ish. And so they postulated that those Hodgkin lymphoma with the EBV infection may be more likely to develop HLH. So probably whether the EBV is like a driver, whether, as what Dr. Dina mentioned as well, which came first, whether the EBV led to the development of the lymphoma and HLH as well. This is a French study also, 34 patients over a period of 40 years. This is all Hodgkin lymphoma associated HLH. So all patients had stage 4B disease. Most cases HLH was diagnosed shortly before or at the time of diagnosis of the Hodgkin lymphoma, and they found that majority of the Hodgkin lymphoma histology subtype was either lymphocyte depleted or mid-cellularity subtype, by 85% of patients. and 94% of them actually had fever or this latent membrane protein 1 positivity in the tumor cell. So this suggests that EBV infection may play a major pathogenic role in the development of Hodgkin-related HLH. I found that because in our patient also it purely appears to be a marrow involvement of the Hodgkin. So there was this case report of an extranodal Hodgkin lymphoma of the bone marrow without any lymphadenopathy. And similarly, it was a young boy, 16 years old, presented with anemia and also constitutional symptoms. He had actually he had only purely anemia. The white cell and platelet was normal. CT scan just showed sub-centimeter lymph nodes. And when they did a bone marrow biopsy, they found the classical CD15 and CD30 positive red Sternberg cells in the marrow. And he responded well to treatment. And there was another one also, successful treatment for isolated bone marrow Hodgkin in a HIV negative patient, which was reported in this journal. And also, this is from Japan, also quite similar to our patient. This patient is actually a 38-year-old gentleman who presented with prolonged fever and then noted to have cytopenia and actually was initially diagnosed as HLH. And then initially he was started on HLH protocol. Subsequently, 8 weeks later, so EBV was positive as well for this patient, EBV PCR. Then 8 weeks later, what happened was they noted like the counts were worsening again and they repeated another bone marrow, and at the second bone marrow examination, they found actually the presence of Hodgkin cells. And subsequently, he was initially treated with this regime, dexamethasone, etoposide, ifosfamide, and carboplatin. However, he was refractory, and subsequently they went on to treat him with brentuximab and AVD. And subsequently, the patient went into remission, and the patient refused hematopoietic stem cell transplant. But so far, for 2 years follow-up, the patient is in remission. What was interesting is they found that when they checked his CD, although his HIV was negative, but his CD4 was actually quite low, about borderline 200 like that. So they say that maybe there is some sort of like T-cell, cellular immunity problem, that could have, or maybe it's just part of the Hodgkin as well. Yeah, quite so. And then they did they summarized all the published reports of patients with primary bone marrow Hodgkin. As you can see, majority are actually HIV positive patients. But very small proportion of non-HIV patients, and majority of the non-HIV ones actually have fever positivity as well. So generally, the primary bone marrow Hodgkin lymphoma tends to be more common in the HIV, among HIV patients than non-HIV, but there have been many case reports. Not many, but several case reports. So quite interesting to see this case. Yeah. That's all, Prof.
Okay, thank you very much. I think it's worthwhile to publish your case law, right? The one that is non-HIV related primary lymphoma associated with HLH.
Yeah.
You try that. If you're not successful in other journals, send to Malaysian Journal of Pathology. I definitely will publish it for you. Malaysian Journal of Pathology is now have impact factor of 3. So
that's Q2, yeah, Prof.
Huh?
Q2, Q3.
3 or reach 3 already. The Scopus one. Psych score. The Scopus psych score is 3 now, I think. Yeah. Okay. Yeah, I think it's interesting when you review the literature. You mentioned about the Memorial Sloan Kettering Hospital series of cases which documented recently, and in fact, one of the conclusions I think you highlighted the value of etoposide in the treatment, and that was actually an observation many years back when I was in training. It was told to us, when you encounter these cases, etoposide will be a life-saving procedure. It looks like it's substantiated. Also, subsequently, like more recent series. Yeah, thank you for actually telling us. Okay, thank you very much for 2 interesting cases. So-called CD30 30 positive.
That's a team.
That's a unifying team for this afternoon presentation. Wonderful. Okay. Any comment from the participant? Yeah. If not, then thank you very much for the Hospital Ampang team. Yeah, we
Thank you.
learned a lot today. Bye-bye.
Bye-bye.
Bye.